Thank you. So good afternoon, everyone. I'd like to remind you the meeting is being recorded, which you just heard, of course. Most of you know me, I'm Melanie Cavalier. I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission, and I am the Program Manager for this grant that you're a part of. So I just want to briefly cover some administrative items. We sent the contact for the MHCC team with any technical issues. Thank you, Anena, for all the support you give to the program. As a courtesy to others, please remain on mute. Staff may mute you if there's a lot of noise coming from your line, but you're always welcome to unmute yourself. Please, well, she said you didn't have to hold your questions. If you do have a question, if you could raise your hand or enter it into the in-call chat box, that way we can kind of facilitate the how the questions are being answered. And then if the question's not answered, you can always, the speaker can respond to you in writing following the meeting. So just to remind everyone, we are offering a round 2 to new practices. So if you know of a practice who you think might benefit from this program, please recommend them to your health coach or Colleen George, who is on this call, and we'd be happy to get them an application. So right now I'm going to turn this over to Julia, who is going to work on training module 3 and enhancing access to care. So at the very end of the module, we will put up an attestation in the chat link, and we do ask that you fill that out before you exit the call today, the training today. Before we start, Julia, Colleen, would you like to say any words to the practices on the line as we start?
Good afternoon, everyone. As Melanie said, I'm Colleen George. I'm with MedChi and the MedChi Care Transformation Organization, which is supporting these efforts as well. I am just here to kind of listen and support Julia because she is the expert. I do have a little bit of knowledge based on what has happened with MDPCP that may be of help. So I may jump in once in a while to just kind of clarify or add to something that Julia says, but she's in charge and is more than capable. So thank you all very much for joining and for being part of this program. You know, as I've said to other practices, I am so enthused by the reaction we're getting from practices about this program and how much they're getting out of it. And to be honest, personally, I find that very gratifying. So thank you for joining and for being a part of this.
So Colleen's being a little modest. She actually leads the organization, and I think there's 24, 25 practices that have been very successful in MDPCP in this care transformation organization. So I would encourage you, if you have questions on these specific areas, while she's on the call, she can help to answer those questions as well. So sorry, Julia, go ahead, please.
No problem. Thanks, Melanie, and thanks, Colleen. And definitely they are an awesome resource to have on this call and know a lot about different programs, but I'm really excited to be here with you. We will have a time for open discussion and questions, but if there's something as I'm going along that you want me to stop on and elaborate a little bit more, or for us to discuss, definitely feel free to put it in the chat or raise your hand, or just jump in. I'm fine with that as well. And with that, let's get started. Let me see. Perfect. Thanks, Anena. So the disclaimer for this is that the content of the following slides are excerpts from the CMS and Medicaid Services Transforming Clinical Practice Initiative, the TCPI, 7 support change packet modules, and this is module 3. And you all have a copy of this presentation. For more information, you can click on the links. Next slide, please. Okay, let me move this over. So what you will find in this module addresses techniques both primary care and specialty practices can adopt to improve access, provide triaging, inform and educate patients, and provide post-emergency department follow-up. The cost and effort will definitely vary depending on the techniques that you decide to implement for your practice, and obviously, you always have to decide what is best for your patients, for your practice, and currently where you're at. But a lot of this information is really, really valuable. So even if you just kind of listen through it all and decide to focus on just one aspect, that's wonderful. And then down the line, you can kind of add more of these techniques. Next slide, please. Improving access and triaging. Next slide. So you want to ideally be able to provide 24/7 access to your care team. And that means enhancing patient access to care is a driver for patient-centered care design, as well as ensuring business operations. Its importance is highlighted in the multiple change concepts dedicated to aspects of improving access. Within these change concepts, there are many strategies and tactics your practice can implement to improve access for your patients. So these include providing expanded hours in evenings and weekends, providing 24/7 access to advice about urgent and emergent care, and either directly with a member of the care team or through a protocol-driven nurse call line, you are available for your patients. Next slide. It's also important to ensure adequate access during regular hours. This means providing same-day or next-day access to a consistent provider or care team when needed for urgent care or transitional management. It also means offering alternatives to regular face-to-face visits with physicians, such as nurse, care coordinator, pharmacist, group telehealth, and or home visits. And this module, I forgot to preface, is going to be very informative. Afterwards, I'm going to go into the change package, and that's going to give you specific techniques and ideas how you can actually implement this in your practice. Next slide, please. Sometimes transportation, lack of childcare, or other social determinants can create a barrier to access, and practices should understand and address these issues to the extent possible, which may mean working collaboratively with community partners. I definitely encourage you to reach out to your health department if you currently don't have a close relationship with them. They can be an incredible resource for your patients and for your care team as well. I have some practices that put information in their waiting rooms and in their exam rooms for patients, directing them to, for example, food banks, or if there's some kind of transportation grants that the health department offers, and just different resources so their patients have more access to the healthcare that they need. Next slide, please. Informing and educating. Next slide. So this slide is really important, and there's two aspects to it. So the first one is learning why patients use the emergency department will assist your practice in implementing the best strategies to address access issues. So you really want to make sure you understand why your patients are going to the emergency department in the first place. The second part is often patients simply do not know what options are available to them after hours or on weekends. For this reason, it's important to communicate to patients any changes the practice makes to improve access to the care team. It's also a good idea to continually reinforce the ways they can interact with care team members, providing information about when and how to contact them during regular clinic hours and after regular hours. So this is really important. One, you definitely want to understand why they're going to the emergency department. And two, you want to make sure that all of your patients know any updates that you have made. Maybe you didn't used to offer evening hours, now you do. Maybe the dates changed. Maybe now you have weekend hours, or maybe you have a certain protocol in place that after hours, this is how they can get in touch with a care team member. So that's really important, because that's going to allow your patients to call you guys first and not immediately go to an urgent care or the emergency department. Next slide, please. Another TCPI change package module, population management, focuses on the need to identify and decrease care gaps for all patients. That's something, if you're interested in it, please let myself or Lisa know, and we can send that to you. Preventing avoidable ED utilization is not limited to primary care. Specialists also play a role. Behavioral health providers can encourage collaboration with primary care clinicians to integrate and improve care and communications. Sometimes care management is necessary to connect patients and families to alternative resources. Here's an example for optometrists, for example. They found that they could address the issue of avoiding ED utilization by expanding access and providing education to their patients on the appropriate use of the ED related to eye care. Many other specialty groups can implement these same strategies. Next slide. Identifying patients who are already or potentially high utilizers of ED may be a good place to start. This is often a small group, and understanding why they use or may use the emergency department will have the biggest and fastest impact on avoidable ED utilization. In addition to looking at actual utilization, use of risk stratification tools help identify patients at risk for avoidable ED use. The process does not have to be complex. The goal is to assess risk factors such as a poorly controlled chronic medical or behavioral health issue, or social determinants such as unemployment, housing insecurity, or others. The whole idea is to really treat the patient as a whole and really understand everything that's going on in their life, and how to improve overall healthcare for the patient, and not just be a place where that's transactional. They're coming in for one problem and that's the one problem that's treated, and so on. Because the more you understand, hey, this patient just lost their job, they're under crazy stress, or maybe there's some reasons why they usually go to the emergency department. The more you know that, the more you'll be able to help them and reduce the costs of healthcare. Next slide, please. Post-emergency department follow-up and local collaboration. Next slide. It's often difficult to determine which patients have utilized the emergency department, especially in large communities with multiple disconnected facilities. The best approach is to collaborate and communicate directly with your emergency departments and hospitals when possible. Then follow up with the patient or family members within a few days of their emergency department visit. Contacting patients after an emergency department visit is important to understanding the reason for the visit, identify questions or any issues, and review medications. Using a checklist for ED follow-ups helps to ensure consistency among patients and to guarantee that all information is gathered and addressed. And I'm sure most of you are utilizing CRISP, where you can get a lot of this information, but it's also good to directly have a communication with emergency departments and hospitals. Next slide, please. If your practice has not yet developed partnerships with local EDs to assist with gathering utilization information, the next best option is to ask patients directly during their next visit to gather data and evaluate needs. Managing care involves assigning responsibility for care management of individuals at high risk, assuring patients get access to their care team when they need it, and following up after every ED visit with a phone call, home, or office visit. Next slide. And that concludes our presentation. Does anybody have any questions so far on any of this information? You can unmute yourself and just jump in.
I'm good, thank you.
Okay, wonderful. If there's no question.
Such a cute picture, Katie.
Oh, mine?
Yeah, so cute.
I was in a wedding. Thank you.
Very nice. You're like glowing in the picture. Okay, so we'll jump into the change package. This one has the actual tools and different tips and all kinds of information that is actually applicable. And again, the disclaimer is that the content of the following training slides are excerpts from the CMS and Medicaid Services Transforming Clinical Practice Initiative Change Package and 7 Support Change Package modules for Module 3. And for more information, you'll be able to click on the link in the package. And remember, this is extremely, extremely valuable information. So this was gathered, it's not all just hypothetical or utopian. This is actual practices and techniques that practices utilize all over the country. This information was collected from 100,000 practices that have gone through this program, and it's what is working for them and what they were able to implement. And some of it is really minor changes, and some of it is more advanced changes. So I'm probably going to go, I was initially going to only cover a couple of them, but I think they're all really valuable. So I'll go through them relatively quickly, and then please feel free to jump in and ask any questions, and we can pause at any point during this. Next slide, please. We'll actually skip the next couple of slides. Change concepts. Let's go a couple more. Change tactics. Identify social determinants. Okay, let's go to the next one. So here are some ideas of how you can identify social determinants for your patients. You can partner with a community to assess and address social determinants of health and health disparities. You can do this by working with a community to address needs related to social determinants of health affecting the practice's population as a whole. Find agencies within the communities that track various aspects of social determinants and can be sourced for data if you're unable to find this information within your practice. And the Department of Health in your area would be a great place to start. You can identify programs that address one of the social determinants to determine whether the practice's patients can benefit from referrals. Use asks and offers with community and government agencies to develop programs to address some aspects of social determinants within the community. Next slide, please. Before I go to coordinated care delivery, does anybody have any questions on the social determinants of health? Is this something you are currently incorporating into your practice? Are you planning to? Any volunteers?
I will ask sometimes about having enough food to eat in the home, but I don't actually have. I think there's a questionnaire, and it seems to be really, really long. I don't actually have, I haven't incorporated the questionnaire into the practice, but I'll ask about having enough to eat.
Okay. Well, it's good that you're already starting to think about it. I know one of my practices, they implemented it part of their intake process in the EHR, where they just have a couple of drop downs. They don't ask 100 questions, but just basic ones, is the person employed, their food situation, housing, transportation, things like that. And it's almost like a drop down that they can really quickly do and have some information. So that might be something good to do if your EHR allows it.
That sounds good. Yes, it's on the list. It just has not been.
I completely understand. And there's priorities for things, but it's good that you're starting to think about it and are asking questions. If nobody else has any questions, let's move on to coordinated care delivery. And after this one, we'll also pause and see if anybody has any comments or questions. Next slide, please. So you want to manage care transitions collaboratively with patients and families. You can do this by assigning responsibility for care management of individuals at high risk for emergency department visits or hospital readmission. Follow up after every hospital discharge and emergency department visit with a phone call, home or office visit. Assure patients can get access to their care team when they need it to support reduction in ED use. Partner with community or hospital-based transitional care services, and at a minimum, find out about those. Routine and timely follow-up to hospitalizations, routine and timely follow-up to emergency department visits, encourage patients to rely on multiple team members as experts, and establish a mutual understanding of the information that should be shared when care is transferred or shared among providers. So one of the ones that I wanted to really point out here was encourage patients to rely on multiple team members as experts. A lot of times patients only want to speak with a provider. And that can really limit providers' availability for it or timeliness. So if you are able to have a care team that the patient knows, for example, this nurse always works with this provider, they're the ones that also build a relationship with the patient, they might be able to ask them questions and channel everything through, for example, the nurse or the medical assistant before only going to the doctor. So I definitely encourage you to kind of let patients know that these aren't just your support staff, they're experts, they work directly with the doctor, they know how to triage if there is an issue, and can be a really great resource.
And you're letting them know that at the appointments, like in case there's something in the future?
Yep, exactly. Like every time that they come in, like, oh, by the way, so-and-so, we all work together, we're a team. If you have any questions, definitely, the nurse can say this, definitely email me first and I will try to get, anything corrected for you. And if it requires the physician, I will definitely get this information to them. But a lot of times
Got
it's
it.
information that the nurse can handle. I can tell you from a personal experience, one of my kids was seeing a GI doctor at University of Maryland, and they had a fantastic system in place where the nurse, you get to know the nurse and a couple other, care team providers before the doctor, and you could build a relationship with them. And the nurse she would respond almost immediately to any emails or any patient portal questions, or if we needed like lab work done or, any kind of test set up or to see another specialist. She really was the main person to go to. And if I had specific questions, I would ask her, and then she would, either get the doctor to call me or respond really quickly by asking another provider, for example, instead of me always calling and waiting for the doctor to call back. So it was actually really, really efficient, and I love their system. So that's just
Okay.
personal
Thank you.
experience. Sure. Next slide, please. Another thing you can do for managing care transitions is develop agreements with specialists in the community that identify goals for communication. Have someone talk with patient and family prior to each transition so they understand what the next step is and what it may mean. Review when care transitions are not optimal and look for themes. Use pharmacists to co-manage chronic disease states under collaborative agreements. I actually presented to a couple practices yesterday, and one does this regularly and really utilizes their pharmacists. They've kind of built a relationship with some of the big ones and some mom and pop type of pharmacies. And then I had another practice that has had a horrible experience with a lot of turnover and issues with pharmacists. So I'm kind of curious if anybody here utilizes their pharmacists regularly. Or does anybody have relationships with their pharmacist?
I have to say that I don't, maybe it's just the local pharmacies, but I will often ask them for help and, like pre-authorizations or, dosing or finding antibiotics that are, on back order. And I don't really find them very helpful, to be honest.
Okay. I mean, that's good knowledge to know. I'm sad to hear that, because I had one practice that said their pharmacists are so knowledgeable and they work with them hand in hand. I mean, it was like this great situation, but I am finding that unfortunately is not the case everywhere.
Yeah,
I'm sorry, go ahead, Katie.
no, we have a really good one too that we use. Like, it's a smaller pharmacy, more of like a mom and pop kind of pharmacy, not, the CVS's that are really good. So for our ambulatory center, we were looking for some medicine yesterday for surgery, and it was on back order, and they're doing a really good job of trying to find us, a way to get it, maybe a different dosage, maybe a different size. So I think it just can go either way these days.
That's nice that you have that.
Colleen, maybe you can weigh in on how some of the MDPCP practices use pharmacists to help with their needs.
That's something that has been like this group that has been successful and not successful, for different practices and how they approach pharmacists. Oftentimes the practices do reach out to their local pharmacies in their neighborhoods, their closest pharmacies, but they do sometimes have issues with pharmacists that are, with the big chains and have much more luck with the mom and pop pharmacies. If you are having issues with the big chains in some of the things that they are not willing to fill or questioning too much, you think. Now, understand it's the role of the pharmacist to, view the PDMP, and you may get questions on filling an opioid or benzodiazepine. But if you're really having problems with your local CVS or Walgreens pharmacy, feel free to reach out to me. We also have a committee at MedChi called Payer Relations Committee, and we are adding pharmacists to that committee, as well as our opioid committee. And we're establishing better relationships between practices and the pharmacies, even the big chains. So if you're having any specific issues with any of the pharmacy chains, feel free to reach out to me, and we'll see what we can do to assist.
That's really great to know, Colleen, because I'm going to have a couple of practices reach out to you, because the ones that do have the relationship, it's amazing, and it really helps to co-manage their patients and get the prescriptions faster for them, and they work as a team, so that can be such a huge benefit. So moving on, you can also pre-plan transition of care appointments when you're able to. Ensure that useful information is shared with patients and families at every care transition. Engage payer disease management and complex care management staff to help avoid patient-family confusion. Next slide, please. Before we move on to enhanced access, does anybody have any question about coordinated care or comments? Okay, let's go to enhanced access. Next slide, please. So the goal is to be able to provide 24/7 access to the patient's care team. And like I said, it does not have to be the provider. And in fact, I encourage you for it not to always be the provider, unless it's some kind of a issue where a provider is necessary. But if the more you're able to create kind of a care team, it takes the pressure off of the provider and gives a lot more time availability also to address patient needs. And here are some ways you can do that. You can create a centralized call center operation to more efficiently manage patient calls. Maintain a patient portal and encourage its use by patients and families. I know probably every practice has a patient portal, but not many patients use it. There's different ways you can incentivize it and really let them know that they can have more access after hours, for example, if they go on their patient portal. You can set up secure messaging system or use direct secure messaging. Provide 24/7 access to provider or care team for advice about urgent and emergent care. Provide care team with access to medical records after hours. That is extremely important, just like the one after it, ensuring providers who are cross-covering have access to medical records. Nowadays, with almost everything being in the cloud, most providers are able to access information, even if it's not their patient, if it's within the same practice. But if you are using cross-covering with a different practice, maybe there's some kind of protocol you can have in place as well. You can have a protocol-driven nurse line with access to medical records and expanded hours on evenings and weekends with access to patient medical records, coordinated small practices to provide alternative hours, office visits, and urgent care. The whole idea is for you to be the primary place for them to seek care and advice before they go to urgent cares and emergency departments. Next slide, please. You can also use alternatives to increase access to care team and provider, such as e-visits, phone visits, group visits, home visits, and alternate locations, such as senior centers and assisted living centers. Provide same day or next day access to consistent provider or care team when needed for urgent care or transition management. I know that's not always possible, but you definitely want to try to make sure there's some kind of time slots allocated in your day for urgent matters. Provide a patient portal for patient-controlled access to health information. Use warm handoffs for cross coverage and implement a 24-hour nurse call line that is algorithm-driven. That's a little bit more sophisticated, but I do have a practice that's thinking about implementing something like this. Next slide, please. You can provide scheduling options that are patient and family centered. You can measure and balance supply and demand of patient access issues and then expand or modify hours as needed. You can continuously test new access approaches, offer alternative visit types to address patient care needs, such as a nurse, care coordinator, pharmacist, group, electronic and/or home visit. Identify external factors that create barriers to access and find innovative solutions. Commit to open access regardless of insurance type. Partner with community resources to eliminate or reduce barriers to treatment access. Value resident continuity whenever possible. And in academic settings, implement a system wherein residents hand off information about challenging, complex patients that other residents will see. Next slide. And I believe this is the end of it. Designate one medical assistant to take acute phone calls, learn about patient and family jobs and transportation, set up a system to accept walk-in visits if possible, and set up clinics for special needs, such as flu shots or sport physicals. Some practices literally have like 1 or 2 people that are designated specifically for flu shots and sport physicals, so it's not taking time out of the main provider's day. Next slide, please. Sorry, there's a couple more. So assess and mitigate barriers to access. For patients with frequent no-shows, ask patients about reasons and develop potential solutions to address them. I believe every practice has some kind of concern about missed appointments and no-shows. So you definitely want to make sure that your staff are asking patients why they missed an appointment. And that's just so that you can learn what barriers exist to potentially them coming in. Is it that maybe they need reminder calls and text messages, maybe lack of transportation, whatever else it is. In this way, you can definitely minimize them. Ask patients before self-management goals are set what might get in the way of following through. And query the scheduling staff and outreach staff about things patients and families say to identify gaps and priorities for improvement. Next slide. This is the last section. Before we move to the optimal use of health IT, does anyone have questions about enhanced access and 24/7 access to healthcare? Is this something you're currently doing, want to be doing? Any concerns about it?
I mean, we definitely have 24 access to leave messages and or non-emergency things. And then we do have an emergency number for our doctor specifically.
Okay.
It's not super advanced, but it is at least a way for them to get a hold of someone.
Do you educate your patients in any way about which scenarios they should be calling you guys after hours and where they should be merged?
Yeah, I mean, we do put it on like their post-op instructions after their surgery, and then we do also try to let them know what is considered, an emergency and what is not. So we can triage it better on the call center.
Okay, that's great. Does anybody else currently offer it or would like to offer it? 24/7 access or some kind of after hours access to the care team?
Myself and my nurse practitioner, one of us is on call at all times, so we alternate monthly. So there's always a way to get in touch with us. We also, try to utilize the portal so that patients can, send not so urgent messages to us, and we'll get back to them that way. We don't really have extended hours. We've done like a survey before of patients, and patients just wanted me to bring back weekend hours, Saturday hours, and I've been there, done that, not going to do it again.
Okay.
So
You know what, how great it is that you surveyed them to at least know this information, then you can decide, is it appropriate or not?
yes. So I didn't, kind of waste time to extend hours if parents weren't going to really do that. Earlier hours, we've tried that for a little while, didn't have so much success. We haven't really done same day office visits. It's just, the manpower in our office is down, and it varies from month to month. So it's hard to think about doing something like that and not to have enough people in the office to help out.
Yeah, I understand. Especially with a smaller staff, some of this can be really challenging. Is anybody else able to do same day appointments? And if you do, how do you do that? Or walk-ins? I appreciate your comments.
We'll
Oh.
occasionally do some urgent follow-ups is kind of what we call it. It just really depends on the provider's availability. We haven't gotten to the point where we're able to like build that into their schedules necessarily, but we do have alternative options. If they can't get in for an urgent visit, we do have like these cases that will open and make sure that the provider looks at it before the end of the day, so that either the patient will get a call back, or if they need to send in a temporary dose of medications to hold them over until, the next day when we do have an opening or something along those lines, then we do have that kind of process in place.
Okay. Wonderful. Do you let your patients know to basically call you guys first before they go? Okay.
Yeah.
Well, wonderful. I appreciate everybody's comments. We'll go through the last couple slides and then open it up again for any kind of comments or discussion that you guys would like. So the last part is the health IT. Nope, that's perfect. Thanks, Anene. And it's, how do you improve patient access to care through innovative use of technology? So here's some ideas. You can use secure email visits, use telemedicine visits for patients in rural areas or for specialty consultations, use home telemonitoring options, instruct on receiving payments for e-visits and e-consults, use text prompts to look at portal messages, use text appointment reminders with permission from the patients, home international normalized ratio monitoring, protocols for monitoring urinary tract infections or upper respiratory infection with a phone call. Next slide. You can also use portal or texting to provide electronic reminders. Use patient portals to avoid unnecessary visit to provider and answer questions by appropriate care team member. Use apps, since almost everybody has a cell phone. Have portal messages go to the team, not just the provider. implement a system for ongoing review of workflow and train on updates, assess access in rural areas and consider alternative web access approaches, use web-based video technology such as Skype for homebound patients. And lastly, on the next slide, is our last Q&A. Does anybody have any comments, questions, either relating to these slides or just in general about the program that you would like to discuss or have a question about?
What were you saying to use Skype for? I'm sorry, I missed that part.
For homebound patients?
Okay.
Any other questions or any comments? Well, I think that's it. I super appreciate your time. Melanie, do you want to wrap it up, or Colleen? Or do you have any comments to add?
No, thank you, Julia. I think this was a great session. So as always, we appreciate feedback from the practices on the program and any of the training sessions. We do have 4 more trainings that are on different areas, but all the trainings are intended to work together and also to support the all of the workflow redesign that we did. So just a big thank you to everybody, letting you kind of know where we are in the program. We have completed 3 of the trainings in the workflow redesign. There are 4 more that we will be doing throughout the 6 months of next year. We will be doing additional assessments also to find out how people are progressing. The team is always available for questions or support. And again, always open to feedback from everybody. So Colleen, did you want to say anything as we close out today?
And I just wanted to jump in. Please don't forget in the chat.
Oh yeah, there's the attestation. Yeah.
Yep. And this will be from module 3.
No, I don't really have anything to add other than, again, thank you all for joining and for participating, and your comments. They're always much appreciated and well thought out. And we are glad that you are part of this.
Nana, can you add the attestation to the chat, please? The attestation link.
Yes, I'm doing that right now.
Yeah. Okay, thank you. So thank you, everyone. So as soon as you do the attestation link, you're welcome to log off, and we're here to answer any questions if you have any. It should look like the other attestations that you've done so far. Just as she said, check the one that says module 3.
Thank you, Julia. Thank you.
You're welcome. It was so nice to meet everyone.
Yeah, we appreciate Julia stepping in today.
Yes, thank you, Julia.
Thank
No
you so much.
problem.
Well done.
And Nene, thank you so much for doing the slides. Super appreciate it.
Happy to. The link is in the chat for everybody.
Perfect.